everybody to our community engagement panel as part of this year's symposium on substance use research, which is aptly named Increasing Access to Research. For today, I am Dr. Bree Shepard. I am the Assistant Director for the WVU Institute for Community and Rural Health, and also I serve as the Co-Director for the Community Outreach and Engagement Corps at West Virginia's CTSI. It's my pleasure today to be here with you on this great panel. I'm really excited to have these four wonderful people with us. And just real quickly, our goals are really to understand ways that people are engaging their communities in research around substance use disorder and provision of services. Some of that which has been altered in light of COVID-19. So without further ado, I'm going to start with brief introductions of our panelists and let them talk a little bit about where they're from and what they do within their communities, and then we'll move into some question and answer sessions. So we're going to start with Jan Rader.
Hi, welcome everyone. I am the fire chief in the city of Huntington, West Virginia. And we came to prominence across the country with a little documentary called Heroin. I have a very progressive mayor. I have a very progressive leadership team. And we have been involved in facilitating good things happening when it comes to substance use disorder and the way we collect data. Because there's so many different layers to this issue that we're dealing with, and we are going to deal with it for a long time. I also worked for about 8 years on my days off in a local emergency room. So I've been a firefighter for over 26 years. I'm an old medic and I'm an emergency room nurse. So it gave me different perspectives on this subject, and those skills came in handy when facilitating new treatment options and ways that we can get our community rallied around those suffering from substance use disorder to make a difference. Our peak was in 2017, and the following year, because of what we put together, we had a 40% drop in our overdoses in Huntington. So they've continued to go down, and of course, until 2020. So they're going up a little bit.
Great, thank you so much, Jan. I'm happy to welcome our next panelist, Alexandra Collins. Alex.
Hi, so I'm Alex Collins. I'm currently a postdoctoral research associate at the School of Public Health at Brown University in Providence, Rhode Island. So I'm an ethnographer, medical social scientist by training. So I've done community-based research for the last 5 or 6 years, primarily in Vancouver, Canada, and now in Providence and Rhode Island at large. So I'm happy to be here. My work kind of falls at this intersection of housing instability, drug use, and access to harm reduction services for folks who use drugs.
Thank you so much, Alex. Our next panelist is Doug Leach.
Hi, everybody. Happy to be here with you all. My name is Doug Leach. I'm the founder and CEO of Ascension Recovery Services. We are a company largely made up of folks that are in long-term recovery from addiction and co-occurring mental health disorders. And we design and develop behavioral health treatment centers around the country. We're active in 23 states right now with programs that we have developed and manage. Also started in West Virginia, an organization called West Virginia Sober Living, and we have recovery houses throughout the state and a peer recovery coach network that is active in about 5 counties right now, and also a job training workforce reintegration program in our state. So I'm in long-term recovery. I'm very passionate about this work and look forward to this panel. Thank you.
Great, thank you so much, Doug. And our panelist, Dr. David Baltiera.
Hello, welcome everybody. I'm David Baltiera. I'm a family physician. Currently, I'm the interim chair of family medicine for WVU in the Eastern Panhandle. WVU has several campuses, so I'm out here. Prior to that, I was a residency program director, and so I come at this from a clinician side and as an educator. Currently, the work that we're doing in substance use started back in 2005, where when I came to West Virginia after being in Chicago, Cleveland, and Idaho. Idaho was probably a little bit of the different place, but the other places it was during what they called the crack epidemic. We had heroin, methamphetamines, but really never had an opportunity to teach people how to take care of that. So in 2005, West Virginia was starting to have its opiate epidemic, and we saw babies that are starting to have NAS 2005, 2006, and it just kept going up. And so we were looking for a way to take care of those. And so in our hospital, it's a critical access hospital, we started taking care of our babies there without the NICU, and then figured we need to kind of address the issue. And so many years later, actually starting in 2015, we partnered with WVU. They had a state opioid response grant to develop a hub and spoke model to take care of MAT and kind of spread that so they train a hub, then the spokes would grow. Our vision was to do that with moms. So we developed the maternal comprehensive opiate addiction treatment program at Harper's Ferry. And that is, the idea is in family medicine that we would provide comprehensive care for those women, not just addiction treatment, but also behavioral health services, their obstetric care, a full kind of range of services, not only provide it, but also teach residents, because we really do need clinicians that not only are sympathetic and understand the problem, but that a certain percentage of them will provide that care. Since that time, all of our residents are trained in MAT. They're all waiver trained. Whether they'll practice it, we hope that 10% will, but that's one of our goals. We're also part of the West Virginia Governor's Demonstration Project, coming up with new substance use disorder treatment plans out here in Berkeley and Jefferson County. And with that, expanding from our MCOAT program, we felt that we needed to provide a bigger basket of services, more wraparound care. And so one of those programs is called CIRCLE, which is comprehensive interventions for recovery through community linkages and liaison. I tell people that's how you get your grants. It's acronyms. That's how it kind of, a lot of it is. And so you have to kind of build those, but it really is a wraparound service for families, anything from a child who's in foster care, grandparents who are taking care of kids that have been taken away from their parents, partners, family members that need MAT. So it's that wraparound care. We also have community outreach teams that go out and connect with patients in the community, whether it's a homeless shelter, whether it's their tent, their campground, wherever they are, to kind of connect them with outreach services, providing on-the-fly therapy and connection to resources and treatment programs. So I come at it from that. I'm actually wish I were doing more of the research. Collecting data is tough, and so we'll talk a little bit about that. But we've been pretty successful with our model of the MCOAT. After a year, 80% of our patients are still in the program, which is pretty, surprising. And we've kind of taken a little bit of kind of a medical model, but also gone against some of the grain, which we can talk about a little bit later if people have questions on that. So thanks.
Great, thank you so much. And thank you all for being here with us today. So we'll go ahead and get started with some questions. So first, can you guys describe some types of partners that you work with in addressing substance use disorder and kind of ways that you effectively communicate with those partners?
So I'm happy to go. I'd say, given kind of the research that I've done, and I also come from kind of HIV amongst folks who use drugs as well. A lot of the partners I've worked with have been kind of nonprofit housing providers, drug user-led organizations, sex worker-led organizations, and harm reduction organizations, so kind of inclusive of syringe exchange programs, but also overdose prevention sites and folks operating supervised injection sites as well. So it's kind of spans health and housing. And I think, in terms of communication, I do a lot of just dropping in and visiting. COVID's made that a little more challenging, and coming to Providence, just getting to know people has been going to meetings, introducing myself, emailing, and just trying to find opportunities to volunteer at the spaces. So really trying to be useful and try to make myself available to be useful and communicate kind of on a more consistent basis that way.
Great, thank you, Alex.
Oh, go ahead.
Well, I was actually going to say, Doug, do you want to talk a little bit next?
Sure. Yeah. Sorry. So we do a lot of work with WVU as well, through the various schools, School of Public Health and Department of Behavioral Medicine and Psychiatry. We do work with some of the harm reduction clinics in the area, in the region, basically anywhere that we might have a touch point for people struggling with addiction or mental illness. And so a lot of the social service agencies throughout the state, and specifically in Morgantown, we have partnerships with. We have various grant efforts that we're working together on, and it's been difficult. A lot of the work that we do, we're kind of the boots on the ground agency that's meeting with people when they're struggling, and COVID has created some barriers there, but we've been able to use Zoom and WebEx and things like that to keep in touch with our partners, connecting with folks that are seeking recovery. There's been an increase in utilization of some of the various apps that are out there. State of West Virginia has the Chess Health app. So we've been able to connect with a lot of people remotely. Certainly not what we like. We like in person the best, but we've been adapting. Interesting times.
So for us, a lot of it's been, starting out from the medical side of the model, and kind of really a belief that although substance use has a whole social structure to it, a lot of the treatment needs to exist within the medical structure, because it hasn't been, especially with the advent of MAT. So we've really worked with the university, med students. We have a variety of other learners that work with us, and they've been very supportive. But one of the things that's actually, I think in West Virginia, we can all probably say is that probably without the Medicaid expansion, this would be really hard for us to do any of this work. So kind of even, people complain about insurance companies and Medicaid stuff, but for us, it's been a godsend. We would not be able to do anything that we do. And it's become easier and easier as they've kind of worked and eased up some of those things, all the treatment that we do, the therapy, medication, things like that. And so then we've expanded from that to what Alex and Doug were talking about, some of the more community. That's the part that we had been missing. So we work with our homeless shelters, Jefferson Community Ministries out here, other recovery centers, a lot of trying to hook up that we can't do all the work, even medically. We need to kind of be able to refer our patients. Also, when they're not successful in treatment, how do you get them to a higher level of care, rehab services, job services, those things. So it's really grown into, it really is kind of a life coaching. I kind of explained to our patients that they're getting concierge medicine and life coaching all wrapped in one, through Medicaid dollars. And so that's kind of our model. But I think a lot of it's kind of building the next generation of physicians and social workers and, kind of learners that can do this to help us. But, fortunately, we've been able to work everywhere from in the hospital. We start people in the emergency room. That's kind of a really neat thing. They're doing connections there, and we're treating patients as they come into the hospital for other medical issues. We start them on there. So it really is on the ground wherever they are. It's kind of like a hotline concierge practice is what we're aiming towards. Not sure we can survive that. It's a lot. It's tough work to be on for that, but that's kind of the model that we're shooting for.
Sorry, my light went out.
I didn't think Huntington had blackouts.
Well, I'm not tall enough to hit the motion sensor, so I have to stand up or wave at it every once in a while. Are you ready for me to go, Brianna?
I am, and I think that the lights flashing was a very, very good intro for you. So
Yes.
take it away, Jan.
Yeah, so actually in Huntington, we started something called just a regular Office of Drug Control policy on a city level. And we started that in the fall of 2014 because our problem was growing exponentially. And we knew that there were people doing good things, but they weren't, they didn't know about each other. And so we facilitated a lot of conversations. We started a lot of partnerships between hospitals and EMS and health department. A lot of times our hospital and our health department just weren't on the same page. We also facilitated legislation that needed to change so that we could carry naloxone for first responders and have a harm reduction program in the state of West Virginia. It's interesting the number of hurdles that you run into when you're trying to help those suffering from substance use disorder. And as a member of the Office of Drug Control Policy, I spent a lot of time putting people together and facilitating good ideas like methods of treating somebody so you didn't clog the emergency room. Now we have a freestanding facility called ProAct where you can go in and be connected into the system within a couple hours. We started a quick response team through our first responders. They go out and they visit people who have overdosed within 72 hours of their resuscitation and offer them services. It's been an experience where you have to actually even retrain people in the medical community and your first responders on basic stigma and how not to make somebody's situation worse just by your words. You know, we spend a lot of time teaching our first responders classes like words matter because the fragile nature of somebody who is suffering from substance use disorder. So we have many partnerships. We stay in touch by phone. I prefer in person, but with COVID, you know, I pick up the phone on a regular basis. Sometimes I call the CEO of one of our hospitals and say, hey, how you doing? How are things? And I think that's important now that we found a way to communicate with each other. I think we need to keep that going because it's going to be years before we get to a point where and then it'll be another problem. So that I think we've all spent a lot of time building framework.
Great, thank you all so much. Dr. Baltier touched on this a little bit earlier, but how do you all evaluate your efforts to address substance use disorder in your community?
That data is key.
Dr. Baltier?
Yeah.
Yeah. Go ahead, Jan.
And we use a lot of data down here. We track our overdoses. We track our overdose deaths. We have implored each individual unit that is working on this problem to keep their own stats. We share them back and forth with each other. But that is key to making sure we get through this.
For us, it's been a challenge. I mean, we wish we could do more, especially when you're working as a clinician. You know, a lot of times we focus on, you know, the individual, the groups we have in front of us. And so, unlike Jan, I wish we had better, I mean, the data may be out there, but we really don't always have access to it. And we really have been functioning. So now we're looking at more of that. So kind of, you know, where the opiate overdoses happening, what's the overall rate. Unfortunately, we haven't seen a decrease in our area. It's been on a continuous increase. And so I think a lot of the stuff people like Jan and, you know, the Office of Drug Control Policy have done, you know, in terms of the harm reduction and that we're basically stealing and borrowing from around the state to do that. We've focused on trying to look at what the outcomes of our program are. And so we're trying to get students currently to go back over the last, you know, 4 to 5 years that we've been doing this and seeing what elements of our treatment are important. In terms of the COPE model that we use, it's group therapy based on half an hour of medical, where I may see 10 or 12 patients at a time. And then they do their more of their therapeutic intervention with a social worker therapist. And so kind of one of the things I'd like to look at is what's the impact of self-help groups. It hasn't been something that we had very available to our patients, so we actually haven't required them to do that. And I don't think our outcomes have been any worse. So there's, a variety of research questions like that. We see our patients weekly. So the question is, are we really, is it our therapeutic intervention that they get weekly, or is it really a modification of contingency management where you don't get, you get better as you get your Suboxone prescription that keeps you coming back? And is that the magic? So I think there's a lot of challenges to figure out in treatment what the magic pill is, not necessarily, not literally, but figuratively. And so we've struggled. I think with this last grant, we're trying to collect data, and we have some help from the School of Public Health in terms of how, what of our interventions matter and what makes a difference. And so that's a big challenge, especially in kind of social sciences, which is what this really is, even though I function on the medical side, is what makes a difference. Is it that personal connection? Is it the outreach teams? Is it, Narcotics Anonymous? And so I wish we were doing better on the data collection, and that's the challenge that I'd like to do more of.
Yeah, a lot of the work that we do is is grant funded. The requirement of that work is to track our data and track our outcomes and be able to prove what we're doing. And if you're not able, then we have trouble getting funding again. So it is really important. And something that's less technical but more observable for me is in Morgantown, for example. Since we started expanding services and providing recovery houses, there was the first one I opened in 2013, and since there's many operators and lots of homes, and so we've increased services. We've added residential treatment, outpatient treatment, expanded access to medication-assisted treatment. And so the thing that you can see is the recovery community is huge. There's just so many people. There's on the self-help or mutual support groups, there's where there might have been one meeting a day, we now have dozens. And so it's really cool to see, as a person in recovery, these meetings grow, these community softball teams that are for some of the recovery organizations. We've really seen the community grow, so that's exciting. So we look at the data, and I can't say that I don't care about it, but I love seeing these faces, people clean and sober, and lots more, and it was mentioned earlier, I think by Jan, about the stigma, but, that's probably one of the biggest things that keeps people from sharing this information, so we can track data, and we can really get that information, and I think things have improved there, over the years, but still have some way to go.
I come from a bit, quite a different perspective, as I'm not, we're not providing direct services, but in terms of evaluating how we are engaging with communities and community organizations who use drugs, and also kind of interfacing it with state level agencies. I think a big way for me, at least, on how I'm evaluating myself and kind of that contribution, is it just reflecting on if I'm listening to what communities are saying and what folks who use drugs are saying, and having that really guide the work. So not so much metrics, but just, is this research contributing to what folks are advocating for and working to kind of meet the needs? And I think our broader team has, work that's contributing to policy change and health reforms. And I think that that's a really key piece coming from this research side of is our research meaningful, and is it meaningful to the communities we're working with, and is it pushing this narrative of change for the better for folks who use drugs, and is it increasing access to harm reduction services and pushing the needle on decriminalizing petty possession and these really key factors that are shaping the health of the folks that we're working with.
Great, thank you all so much. We do have one follow-up question for Jan. How do you track your overdose deaths in Huntington? There's typically a big delay getting data back from a medical examiner. Do you have a system that may track suspicious or potential overdose deaths? If yes, how does that system work?
So we can track it unofficially through our 911 system, through our local EMS system. We don't know the overall count or the vetted count and until sometimes up to a year later. But we have a pretty good idea, and we utilize that 911 system. There are deaths that are happened in the hospital that EMS did not respond to, that probably about 20% of the overdoses in Huntington are driven to both emergency rooms by personal vehicles and dropped off. How we track those is we have an agreement with both emergency rooms that they call our 911 center to report an overdose brought in by personal vehicle. And they just give basic information, male, female, age. And they don't say whether they lived, died, what drug was involved or anything. That's how we get around the HIPAA. And then we can collect that from our 911 center. So the data that we do have is not vetted until much later, but you have to know what exactly is happening in your community before you can affect positive change. And that's something we did very early on when we started the Office of Drug Control Policy.
Great, thank you so much, Jan.
You're welcome.
So what are some of the challenges that you all have faced in doing community engaged work, and how have you been addressing or hope to address these challenges?
I'll go first. We spent a lot of time educating the general public before we ever started the first syringe exchange program in the state of West Virginia. We started with who we thought would be against us. We started with our politicians and our churches. And we would do this education in very small groups, 10 and under, so that you didn't have that one loud voice that started a rumble. And we were pleasantly surprised that churches really embraced what we were saying, and they have been one of the main reasons why the faith community has been one of the main reasons why Huntington has been successful, because they have really stepped up to the plate. Now, we will fight stigma for years to come, but we continuously talk about it. You have people in the community that have stepped up to the plate and will do public service announcements. And we had a couple athletes that are in long-term recovery step forward and tell their stories, and that has been huge. We've had barriers such as legislative or state and local laws that interfered with our ability to do things that we wanted to do. We needed expansion with Medicaid, Medicare. I was in a lot of meetings with people trying to get those changes done so that more people could receive the help that they desperately need. So I think that there are a lot of boundaries, but I think that there's always a way around it. And some of it's long-term and some of it's short-term. But the more people you get on the side, the better off you are.
I'd echo what Jan said there. Probably our biggest challenge has been the not in my backyard, stigma of around addiction and mental illness. And so, it can be frustrating as a person in long-term recovery to, get opposed and to hear some of these things that they say in these town hall meetings, but what our approach has been to educate. A lot of times there's what we found is people that are the most vocal about not having resources. They might be hurting themselves. They might have a loved one that is struggling with addiction, and so there's all kinds of feelings and so we've tried to be understanding and hear the concerns, but really educate people on what is this that we're doing and we're trying to bring to the community, and helping people understand that the problem is already here. We're not bringing in a problem to a town, that this problem exists everywhere. And so I have seen that change over the past 10 years. Areas where they would block out treatment, and for example, if anybody's seen the Netflix documentary Recovery Boys, that program was opposed in just a major way. I mean, a town hall meeting that was just brutal, and once it opened and people see, this is non-threatening, this is helping, and it's an asset to the community, and the community really supports that program. So I've seen things change. I think, as Jan said, I mean, it's something that we'll always battle and try to combat and combat through compassion and education. So that's probably the biggest hurdle I've faced.
Yeah, for us, it's kind of the harm reduction has been really hard in our community. So I'm glad Jan's had success with that. Ours, it's been a challenge, but in terms of other things, it's actually been quite hopeful. And part of it's we've normalized, treatment for this disorders, and kind of normalized how we take care of patients and kind of leading by example. So fortunately, we're a small hospital. We're a 25-bed critical access hospital. And by, having the motto where moms and babies stay together, the nurses slowly have become to accept that. They don't know any other way. We've been doing it for, quite a while. And we almost did it by accident. It's just the way it was because of the structure of our hospital, as opposed to when some of our patients deliver at other hospitals, they don't get that feeling. So it's kind of continuing that. And that's where it's been a challenge. At the same time, using our patients and clients, their stories. We talked about collecting data, but as Alex and Doug talked about, a lot of times it's the stories that are the most powerful. So in terms of impacting our third-year med students, we actually have our patients, our moms, and even our dads that have had children that have been affected with this, and they themselves are in recovery, have come and told their stories. And not everybody that's come and spoken has been completely successful. They're still working on it. And so those stories were really powerful. And so that has given an impact where this is what we do. And actually, surprisingly, in terms of residency training and recruitment, I'm amazed when people ask us about our programs and they go, oh, I really want to come to your program because of this. So there is kind of a hope out there of people wanting to take care of this. And so it's not as bad as we think. At the same time, I've personally been reported to the Board of Pharmacy for what I do and what I prescribe, and had to go, defend myself, not the Board of Pharmacy, the Board of Medicine, defend myself for that because of the way I take care of those people, the way, people, and so it's, I found that, that probably isn't the most effective way. It's kind of the slow and steady. So me retaliating against, the Board of Pharmacy for somebody who's turned me into the Board of Medicine is not an effective way. And that I did not do that, but it is kind of, it brings it to face that what we're doing, there are people very much against. At the same time, we've been very fortunate. Our ER physicians here have on their own jumped on board in terms of prescribing patients and that. And so, but we continue, we have a whole, couple people on our team that all they do is stigma reduction and kind of reaching out to the community with education. And there's so many elements of it that, you kind of, like I said, the churches are good potential allies, our legislators, medicine, all that. And so we really need to slowly chip away at it. And I think when they see success and when they see people that are doing better from their own profession, even, it makes a big impact. But how we treat people really has an impact. It's leading by example, I think.
And I think kind of from a researcher doing community engaged work, I think one of the most challenging pieces that has kind of occurred over the last few years is how do you meaningfully engage community organizations in the middle of an overdose crisis when their clients are dying and when friends are dying and when family is dying and there's no space for grief, because a lot of these organizations are incredibly underfunded and people are working exceptionally long hours doing this outreach, kind of frontline service delivery. And so, in Vancouver, a lot of where the bulk of my work has taken place. I mean, we were the epicenter of the overdose crisis in the whole country in this one neighborhood, and all of our community partners were, including folks that I worked with, are actively using drugs, and so they're worried about their own lives as well as trying to do research to address the needs of their own communities. And so I think finding a balance of meaningfully engaging partners in the research and involving them to the extent that they want to be involved in, but having that flexibility to see like people are stretched so thin. And then now, with COVID, that's layered on top, and with the housing crisis and a growing number of folks who are unhoused, that was both Canada and Rhode Island as well. Like these are so many other layers that are directly impacting folks in our community, but also, the community partners that we have at the local level. And so I think that's been at least for me, a big challenge of where do you draw the line? Like you want people to be engaged and you want the work to be driven by community partners, but you also don't want to create more burden and more stress and be just a headache. So I think having a lot of kind of communication and being quite flexible and just telling folks like however little or much you want to be involved is perfectly okay, like and that can change over the course of the project, and I think giving folks space to try to just grieve if they need that, whether it's debriefing with colleagues or just having leaves if they work with us, has been, kind of how I've navigated it. But yeah, I'd say that's a continual challenge.
It looks like Bree may be frozen here. Let me see if
Yeah.
I can get her back. Bree, can you hear us? She's having some technical challenges. Are you back, Bree?
I am. Sorry about that. It's for whatever reason, every few minutes it's kicking me out and then bringing me right back in. So sorry for missing the end of that. We did get a follow-up question for you all related to that in terms of, could you talk just a little bit more about how COVID has impacted your ability to engage? We've touched on a little bit already, but how has it impacted your ability to engage with the groups that you work with? And have you found some additional solutions or workarounds during this time that have been beneficial?
Yeah, it's been challenging. One of the early thoughts, we have lots of recovery housing and multiple people living in a home together, and so the question is, about the risk of COVID and transmission, and so we pretty early on, it's this is a life-threatening disease, and we talking to folks that access our services, kind of the risk of being isolated and by themselves, was higher than potential risk of getting COVID. And so, it was challenging for us. So it's, we want to, if we're going to provide housing for folks, in recovery, how do we keep people safe? So we, following the CDC guidelines with face masks in the home, not sharing, drinks and silverware and plates and things like that. And then we disinfect the homes about 3 times a day. So it's been pretty tedious. At this point, I think we're in a pretty good routine. And then, folks that live in our homes that participate in AA, NA, refuge recovery, smart recovery, for a while there was 0 in-person meetings. So they would have to do this remotely in groups of 2 or 3, kind of sitting apart and through Zoom. So it was challenging, but that's how we adapted to it. We also had folks that, that were unable to work. They worked in the restaurant industry. I mean, that's just kind of a big, we call them sober jobs. You get sober and it's you can go find a job pretty easily. It's low stress and you make some money. And so with the restaurants all shutting down, that was a challenge. So we really looked to leverage some grant funding and charitable contributions, and we kind of all pulled together to provide, because now we have folks in the program who are quasi living independently, but using our services, but they have no money for food, or because they're unable to work. And so it has, I would say it takes a village, and we've all been working together and being transparent with our community partners, and so that's been a really cool thing for us, is kind of getting through this. We've been fortunate that we haven't had anybody test positive for COVID in our recovery homes. It's probably a miracle that hasn't happened, but anyway, that's kind of how we're doing it at that level.
On a city level, we recognize very early on that we needed to expand our city mission and a place where we could expand congregate housing and have non-congregate housing for people who either had underlying conditions that made them susceptible, or those who are homeless who ended up coming down with COVID or that were tested positive. So, or actually just needed to be quarantined. So we worked with our local coalition from the homeless and some long-term recovery homes, and we were able to secure 22 or 24 hotel rooms at a local Econo Lodge that does not share a common, it's outside, is how you get into 2 levels of this hotel. And that has been very successful. The city helped with funding for this, and we were able to secure some grants for that. So hopefully we've had a couple homeless individuals that have come down with COVID. We've been able to get them the help they needed. And at our non-congregate housing, which was this Econo Lodge, we also arranged for visits from medical staff and through PROACT, so that people that were in long-term recovery could still get Suboxone or whatever they needed and the services they needed. So it's, I'm glad we put that in place. We've been able to keep a lot of people healthy that we were really concerned about.
Yeah, COVID's been really a big deal for us. And I think as the other panelists have described, it's actually challenged us to come up with new solutions. And I think in the long run, there will be some benefits to it in terms of video, how we're communicating with people. But initially, when it first started in March, April, we really had to pull back our outreach teams because nobody knew how bad it was. I think we have a different understanding medically now. It can be done more safely, but as Doug said, this is a life-threatening illness. And obviously me as a physician, people say, oh, well, seeing your patients is very important. But we were even to the point where our Narcan training, that's life-saving. We have to continue that. How do we meet with our, community partners in safe ways? And so fortunately, being the summer, there are pavilions outside the hospital, meeting one-on-one, making sure our teams had all the protective equipment that they needed. We were able, even in the midst of crisis, secure masks for our patients and clients because they were at high risk. They really are, at high risk of if they contract COVID. Many of them have multiple medical problems and issues, and so it was making a mindset of saying this work is really essential. It's COVID's real, but it's a potential infection. A substance use problem is a life-threatening illness. And so keeping our teams out there at the same time, just as we were starting, they had to pull back. And so a lot of the community engagement is what suffered the most. We were able to continue much of the patient care, but the community engagement, the stigma reduction, can you have a mini rally for, Narcan education on the front steps of the library? Well, probably not. Some things that we had planned as things were coming down, all of a sudden the next week there's an outbreak and that is no longer allowed, 25 people. And so it was just really trying to be creative through that. It was a big challenge, but the biggest part was meeting with the community engagement stuff, churches, and that was a big challenge.
Yeah, I mean, I kind of echo what folks have said. I mean, for us, a big piece was meeting institutional requirements to ensure participants are safe, as well as our team. So a lot of lengthy safety proposals and COVID proposals getting put forth. But in terms of still getting out in the community, we've been still able to engage. I mean, a lot of stuff has gone remote just in general, but our community partners have continued to do amazing on the ground work. And, so for International Overdose Awareness Day, there's a lot of safety protocols that our partner organizations developed, but we were able to have this really lovely, large statewide event of mass naloxone distribution. And it was a lot of hand sanitization and masks and, staying 6 feet apart, but it was all outside and across the state. So we've still been able to, like folks have said, people have been very innovative and being, very cautious about the risk of COVID. But we've still been able to, through maintaining, what state policies are and institutional policies are, still be able to have that engagement, at least, in the latter part of the summer and early fall.
Great, thank you all so much. So a question from attendees. How are each of you dealing with secondary trauma and compassion fatigue, particularly with first responders or healthcare workers or frontline service providers during this time?
We have a quick response team, very similar to the Huntington QRT, and we've collaborated with them on a couple of different efforts, but ours is called WV Peers. It's a partnership with WVU Health Science Center. The peer recovery coaches that are out, and that's who we specifically work with, are the peer recovery coaches. It's been a very trying time, and so we have seen overdoses spike throughout COVID. We've seen it's just, there's been a lot. What we've tried to do was add in self-care days. So and we've done this pretty frequently, where we give everybody, the day off. They, if the weather's nice, they kind of do a team building deal, outside somewhere, or, just take time off. It's paid time off, doesn't count towards your vacation, but, so folks can go do things for themselves and take care of themselves. We've also had some regular check-in meetings with our teams, and just, it's almost like a therapy session for ourselves, that we're kind of sharing what's going on, because we have absolutely seen this, and we've seen folks that are have directly experienced and are affected by some of this and have lasting traumas. So we've tried to be pretty mindful of that. I think it's dealing with an epidemic that's while there's a pandemic going on, has created a lot of panic, a lot of stress, and it's been hard. So that's what we've been doing. I think for the most part, our folks are doing well. The self-care days that we give are well deserved, and they're appreciated by our folks.
In Huntington, we actually started about a year and a half ago, a wellness program for our first responders because of what they see. I actually have one firefighter that has been on 12 of his classmates' deaths. And preparing somebody to do that on a regular basis is not easy. Our program is called Compass, Navigating Wellness. We have yoga classes in fire stations. Several times throughout this pandemic, we have gone virtual on our yoga classes. We offer incentive to our firefighters. We provide off-duty massages for them and things like that. We were doing a lot of family events, but we can't do that because of COVID. But we're trying to find ways to show appreciation to our first responders. We have an embedded mental health counselor that they can, that has been checking in on the guys all throughout this. And I say guys because I'm the only woman, but but it's been very helpful. We also have a exercise physiologist that is embedded with our police and fire departments that can help with nutritional needs and exercise programs. And a lot of the first responders have taken advantage of that. Our hope is that eventually this will spread and be offered to even like ER staff, people that are on the front lines of substance use disorder epidemic and the pandemic that is COVID.
Yeah, for us, it's a challenge. I mean, because you're right, you've got a pandemic and an epidemic, and there's multiple levels of trauma. So the first thing was trying to figure out what are people comfortable working with. So we've been very flexible of saying, you know, if you're not comfortable doing one-on-one work with people because of COVID, we made accommodations for that, provided people with adequate safety equipment. And as it's progressed, you know, people have become more comfortable with seeing people one-on-one. And so we've, you know, provided kind of systems things that, you know, is protective. At the same time, anytime you're doing this work, particularly our peer recovery coaches, they're in recovery themselves and being very aware that we're potentially putting them in very traumatic situations, working with people that are, you know, going through many of the things that they've gone through can be helpful to the person being coached, but it also can be very triggering and cause, you know, kind of reliving of some of that trauma and put people at real life risk. And so we've actually had people that were not able to continue in their job with us because of that. So that really made us very aware to say we need to do more. And that really didn't have it, you know, and then you throw COVID on top of it. So we're really putting people that are, you know, have had a history of substance use at higher risk. So putting in systems so that they're taking care of themselves. I really like, Doug, those, you know, kind of free days for people to kind of recover. It's essential. And just being aware as part of a team that we need to do that. So in our meetings, we increased, not our meetings, but kind of meeting of people, you know, because nobody wants to meet any more than we have to. That's kind of very tiring, but giving people just time on the Zoom meetings to you know, leadership step out and let people talk with each other. That was very helpful. And we felt we really needed to put that into place. The other thing that we've noticed is when this hit, there was an incredible concern about all of our patients and clients. You know, this is, you know, a life-threatening disease. And so all of our social workers, case managers, physicians were putting a lot of themselves after hours, 24 hours a day, 7 days a week, because we felt that there was a lack of access. And so, you know, having to say, okay, we need to put some of those boundaries back in place because, you know, yes, this is a life-threatening disease, but people need to also have their own responsibility. And, you know, some of those boundaries are real important and we can't be working 24/7. And so it was a mindset change in that sense. And so I think COVID was a challenge with that. And even for a lot of our patients and clients, they were struggling with this. Initially we saw a lot of our patients actually doing better because they were isolated from their source of substance use. And then it got worse because the stressors got to them. Patients had to go to work or lost their job, and they created new stressors, and the default coping mechanisms a lot of times is substance use. And so kind of helping people build up new coping mechanisms and increasing our therapy availability to everybody has been key. But can't say we've done it perfectly, but just an awareness of that and putting people at risk through all this time has been important.
We're not, our team is not first responders by any means, or healthcare workers. But similar to kind of, there is some, we are hearing through, interviews, hearing of folks' trauma. And so kind of on our team, it's been this, these ongoing workshops of trauma-informed work and of how to kind of work through some of that stuff, and some of these intense traumas that you are hearing. And, in the midst of like the peak of the overdose crisis in Canada, I was, doing ethnographic field work, and I was, in overdose prevention sites and in people's housing when they're using, and sitting with them as they were using. And so I think, finding ways to, and this is definitely from a research perspective, work through some of that, and some of the stories you're being told as you're, potentially playing dual roles of first responder and researcher. And I was also a student at that time. And so kind of working through, which for us was a lot of debriefing with colleagues after, and definitely seeing therapists regularly, and then having this space, just, taking these days, like Doug mentioned, and just trying to carve out that, being very mindful that, you have to, make time to rest. And so a little bit of that, definitely nothing at all to what first responders and healthcare providers are facing, especially, with overlapping health issues. But I think these are all, y'all have brought up really wonderful things that people are doing. So kind of from the research side, a little bit of that's happening
Are
too.
you analyzing us a little bit, Alex? Some ethnography there.
No, this is all
That's
great.
good.
I
No, it's
really
good.
liked this, Doug's open air kind of group sessions. I think it's a really, wonderful idea. And I like this idea, like, here people are normalizing that these are really tough things that people are dealing with on the front lines, and making sure that, as, a researcher, that I'm not adding to that, but making space for people that we're working with to have that time.
Yeah, I think
Just
oh,
Just to
go
let
ahead,
you know how hard it is on your first responders. In 2017, that was the first year that there were more firefighters and police officers that died of suicide that died in the line of duty. It's the first time it ever happened, and it's been 3 years in a row.
Yeah, and I think also, Jan, in these smaller communities, I mean, everybody knows everybody else, and they are attending their high school friends, parents. There's such a connection in so many ways, and I think COVID's added to that, because again, it's the same. We're not seeing the thousands and thousands of deaths in West Virginia, but everybody knows somebody who's had that. The one, and again, not want to say it's really a positive, but it's given people a shared trauma in a way that can, for our groups, has actually been a good way to talk about coping in that, because everybody's going through some of that to some degree. So they've been able to discuss that both the patients and the therapists to some degree. And so there's an understanding of that. And so it opens up some level of communication if there is any positive to it. I'm not, trying to paint a very rosy picture on it, but it does give people a shared language on that.
Great, thank you all so much. And I think that having the multiple perspectives from both service provider and from the clinical side and from the researcher side is just really informative. Can you all identify any unique aspects of community engaged work with substance use disorder, working with rural populations compared to maybe some of the more urban populations you've worked with?
I think it's important to use the resources that you have. And I think leaning on the faith community is huge. They're an enormous resource and can, they need help in learning how to deal with those struggling with substance use disorder. We actually had a lot of training for our faith community, but what they can offer is so much more.
And just to kind of follow up on that, also small businesses too. So we found out our outreach teams, for example, went out to the local, small general store or Dollar General, to kind of give them information on, kind of what treatments, and they were very open to that, local gas stations, 7-Eleven, things like that, because that's where people hang out. That's where they go. That's where they buy their cigarettes. That's where, they get
That's
food
where they overdose.
right. Unfortunately, yes.
Yeah.
And, right. And it's all those places, parking lots, places like that. And so engaging, it was surprising to us how engaged those business workers and owners were, because they face it. They see it every day. The gas stations are open 24 hours and things like that. So that's been, I think rural communities do have challenges in West Virginia. I mean, they talk about broadband, and in this, we don't have broadband. We even see Dr. Shepard right now, that's probably a broadband issue where you're getting loose. But even in our, towns and cities, it's such a challenge to get people, so the video has been life-saving, but it highlighted the disparities that our communities face. It's not the same, that, and I can just imagine we're in Charlestown and Martinsburg here, but I have patients that live up on the mountain, and, we cannot get a phone call to them half the time. I currently have a client who's living in a camper up in Cape and Bridge, and, she gets her Epic MyChart, electronic medical record messages 2 days later when she drives into an area that has service. So, and that's a big challenge. And I think it needs to be highlighted about those disparities. At the same time, many times the transportation issues in that are just as acute in the inner city. It's just a matter of, distance and population and access. But the transportation issues have been big, getting people to groups. So we've opened up. Video has helped, but it's not helped everybody.
Nothing really new to add. I mean, that you guys nailed it. I mean, transportation in a rural state like West Virginia and other rural parts of the country that we work in, that's the challenge. So it's kind of like a positive that has come out of this is that we have moved more digital and using apps and phone calls and things like that. The challenge is the connectivity that you mentioned, and it's more difficult in other areas. But so I think we're all learning how to deal with this virtual connection. We saw participation rates drop, then they're starting to climb back up. However, some of the challenges, folks that are might not be as engaged. They might show up and participate in a Zoom session, but we're not able to urine drug screen or do other things, and some so it has made things a little bit more challenging. I do think from the work that we're doing that we're getting a little bit better at it. I look forward to a time when we can have a hybrid of, in person plus, utilizing the technology. I mean, I think technology is it's a great tool for SUD and mental illness, but we certainly need the other part too.
I'm a hugger. I need hugs.
Me too.
Well, I agree. And like Doug said, we have one of our groups that just threw their hands up and said, we need to see each other. And so they're meeting weekly in the pavilion until last week when there was a big thunderstorm and you couldn't hear anybody talking, the 6 to 12 feet away from each other. And so we had to say, okay, we're probably now going into winter having to go to video. But yeah, people need that connection. It's funny. It really is critical to what we do.
I'd say I work generally thus far in urban areas, but and to be fair, Rhode Island doesn't have any technically rural areas. It's just kind of urban and suburban. But in terms of how to do research that's more encompassing of folks that don't just live in the city. I mean, I think that's kind of one of our main kind of foci is how do we reach folks. And so I think one of the, at least let you know, it starts next week. I'm really just kind of going out with outreach workers that do kind of work in outside of the main kind of urban core of the state, and literally just driving behind them in my own car and trying to reach folks that way. And so I think for researchers, again, they're definitely people who can speak to probably much more efficient and ways of doing that. But at least here, trying to lean on these folks who already have these really wonderful relationships with people and work to keep expanding kind of our whose voices we're capturing in research. And because their needs, like Spence said, transportation is an issue here as well. And the location of a lot of services are kind of in Providence predominantly. And so for someone living 40 minutes away who has to take a bus, and that bus only comes to Providence once a day, that's like creating a lot of gaps. So I think trying to find ways to capture them in a meaningful way in research is something we're still working on, but I think trying to literally meet folks where they're at is one way.
Great, thank you all so much. I want to take this opportunity. We've got just a few minutes left in our session to open it up for any additional questions from our attendees.
I have a question for the other panelists. If they, a lot of our patients and clients, in terms of research, come in and out of, and so it's a really hard thing to measure sometimes outcomes because it's a process. And so many of the research things that we look at are after 6 weeks, this many people are doing well, or after 3 months, this many people are doing well, or after 12 months, this many people are doing well. But many of those people come in and out of whatever systems we're providing. And so I think that's a big challenge in terms of the research. I don't know if anybody had any ideas on that or thoughts, kind of as you're gathering data, because a lot of our, it's, in smaller communities, it's similar people or the same people a lot of times.
Sorry, can you at least on my end, it broke up when you said a lot
Oh,
of,
sorry.
at the very beginning, a lot of people come in and out of what?
Of our programs. So it's a
Oh.
lot of our clients are, it's not that you come into a program, go to Doug's recovery houses and they're done. It's you go out in the community and you come back and, and so there's, a process to all this that may be years of recovery, and it's not a one shot, 30-day program.
And yeah, so how does one capture that?
Right. And that's what,
Yeah.
we don't do very well at capturing that.
Yeah, I think, for my work is, again, it's all qualitative, but it's definitely coming from the perspective that all of these are ever-changing patterns of use or treatment, and that these cycles are very much part of the process. And so I think like longitudinal cohorts are a great way to kind of track these changes. If in data purposes, for me, I do try to do follow-up interviews. That's challenging when, I do work predominantly with unstably housed folks or unhoused folks. So, keeping in touch can be hard, but kind of doing these follow-ups over the course of a year or 2 years and trying to probe around these events and really understanding like what was a trigger to that led them to start medication for opioid use disorder, or led them to inpatient treatment, or to injecting again after a period of not using. And so kind of looking at factors that way, but definitely trying to, this is a continuum. And so trying to adapt the research to follow folks in that way. Sorry, Jody is, oh, so Jody joined us. So I feel like that's maybe our time is up. I don't know.
Thanks. Thank you.
So our time is almost up. In fact, that will be the last question that we are able to take. I just want to take a moment to thank all of the panelists again for this really informative conversation and discussion. And I encourage everybody to stay on for closing remarks here in just a moment.
Thanks, everybody.
Yeah, thanks for having us.
Yes, appreciate the time.
Thank you.
Hey, Jennifer.
Hey, Jody, how are you?
I'm good. I think we have an audience out there.
Are you still at your beach place?
I am not right now, but
Oh, I was so jealous.
it's pouring rain and about 50 degrees here.
Yeah, it's not much warmer here. So
So, well, I guess we can chit chat, or I can start to make an informal introduction, because I first heard about you I heard about you before that, but we were thinking about, gee, we need to get somebody for our external advisory committee. Who could that be? And Tracy said, oh, there's this really cool woman, Jennifer Havens. We've got to get her. And
well, Tracy and I have been friends and colleagues for better part of 15 years now. So there are very few people in this world I think I admire in the research world more than Tracy. So I appreciate that. That means a lot coming from her.
Yeah, no, she's great. When the Josh Sharfstein suggested that we should set up a governor's task force to address the opioid crisis in Rhode Island. And he said it should be a strategic plan, give them 90 days to come up with a plan, and it should be an expert-driven process, not a stakeholder-driven process. This typical stakeholder-driven process, all the stakeholders say, hey, I have a good idea, why don't you fund my program? And you come up with a laundry list of things and nothing gets done. He said, this should be expert process. And I said, oh, that's great. Wonderful idea, Josh. Who are these experts you're talking about? He said, oh, you and Tracy.
Yeah, exactly.
Well, let me get this straight now. You want me to donate untold numbers of uncompensated hours of time, and I get to work with Tracy, and we get to come up with a plan for the state of Rhode Island for the opioid crisis. Okay. So anyhow, I said, absolutely. Sign me up. If I get to hang out with Tracy, life is good. We are very fortunate.
Lights here for just a second in my house because I think it's going to get dark really fast. So.
Okay. Well, whilst you stepped out, I can start the introduction. So we are very fortunate to have Jennifer Havens, not only as our closer for this week-long symposium, but we're also both Nebraska and our COBRE have the honor of having her as a member of our external advisory committee that really guides us in all aspects of what we do. So we're very fortunate. Jennifer is a product of the University of Kentucky, and after getting her PhD at Hopkins, joined the faculty in 2004, where she's been ever since. Been extremely productive. Recently got a $15 million NIH grant to study hepatitis C treatment in Perry County. So Jennifer, take it away.
Thank you so much. It's been such an amazing week, and I'm really honored to close out this year's symposium on substance use research. First of all, kudos to the organizing committee. This is not easy to be able to do this in the complete technical environment. And I feel like it went off without a hitch. So absolute kudos to this group who did just ensure that this virtual meeting was exactly what it needed to be, and everyone got to have the discussions that they needed to have. And there was still opportunities for networking and hearing about all the amazing work that people are doing around the country. So we were very fortunate to have 2 of the 3 substance use related centers of biomedical research excellence, or if you've heard all week, the COBRE, represented, as well as the West Virginia Clinical and Translational Science Institute. Inclusion of these geographically diverse groups, such as the ones assembled here, really allows us to learn from each other, how we're building community coalitions, which we just heard about, how to secure funding, how to deliver the most innovative interventions aimed at people who use drugs, and how to leverage the resources that you already have in areas that are often the most resource deprived. So we spent much of this past week discussing issues that may not necessarily be unique to rural areas, but these issues make substance use feel more acute or more immediate in the rural US. So I recall a meeting I was at in 2013 where I was asked to appear on a panel to wrap up the day's events. We were gathered to discuss hepatitis C treatment among people who use drugs, and I was asked to provide the rural perspective. As it happens, I was seated at the far end of the table, and my 3 colleagues provided these incredible perspectives and suggestions on how to move forward to address the hepatitis C crisis among people who use drugs. And remember, this was 8 years ago. We were just starting to figure out, hey, we're in the midst of an opioid epidemic. However, I was seated next to folks who had been part of the community of people who use drugs and have been conducting research in this community for years. And they had some fantastic suggestions. So right to the left of me was a representative from the United Nations who spoke eloquently about mobilizing drug user unions. 2 seats down, a researcher from a large US city suggested leveraging existing resources that were established to provide HIV treatment. And the first panelist to speak was from a progressive Canadian city with a robust harm reduction program that we're all very jealous of. And they were using those existing harm reduction programs to provide testing and linkage to care already. Needless to say, after those remarkable presentations, it took me a moment to collect my thoughts and think about how I could possibly follow that up. So I thanked my colleagues for their excellent suggestions, but noted that in order to contextualize the rural perspective for addressing hepatitis C, I would need to take a step back and look at this issue from the lens of those in Hazard, Kentucky, population 5,000. In 2013, they were knee-deep in the prescription opioid epidemic. Overdoses, pill mills, opportunistic Suboxone clinics. More than half the children in the county were being raised by their grandparents. If you talk to leaders in the community, they would tell you that an entire generation has been lost to substance use in Hazard. So in thinking about how to address hepatitis C among substance users, I basically said, I don't even think we can talk about hepatitis C at this point. When hepatitis C was really seen as an unfortunate side effect of opioid use disorder, and at that point, there was absolutely no handle on opioid use disorder. So, I'm astonished by people who use drugs who can unionize. We haven't seen that a whole lot in the United States, but I really think that's something that we can push for. We're always saying, and I've heard it several times this week, that when we're thinking about planning interventions, we need to include people who use drugs, people who are actively using drugs in planning. So this might be one way in which we can capitalize on people who use drugs, people who are actively using drugs, in order to mobilize. And certainly they've been exceedingly successful in Europe in pushing forward programming and policies, but we just haven't seen that here in the United States. And in terms of leveraging resources that already existed for HIV, and until we saw the HIV outbreak in Scott County, Indiana, which is a predominantly rural, a very rural county in Indiana, we weren't even thinking about HIV. So certainly there still to this day, thankfully, there's not a whole lot of HIV, although we are seeing pockets, certainly in West Virginia, for example, the Huntington and Charleston area, but we haven't seen anything on the level of Scott County. And so there aren't really enough people living with HIV in those communities such that we would have already established this treatment cascade and that we could then utilize to address hepatitis C. So again, a fantastic idea, but not something that we're going to be able to necessarily do in rural areas. And then finally, while I would love to have those amazing harm reduction programs that are in some of our big US cities and certainly in our Canadian friends, until the Scott County outbreak, at least in my state in Kentucky, we didn't even think about harm reduction. We didn't even talk about harm reduction. It was certainly, a term that we weren't really allowed to use if we were talking with policymakers. So the reality is that the majority of the time in rural areas, we're starting from square one. We have no existing resources, no program to leverage. So that's why meetings like this one are so important to discuss what is working and what is not in rural communities, and how we can make the most of the limited resources that we often have. So in thinking about harm reduction in particular, I had a conversation a couple months ago, and especially, everything is so much more, again, acute during COVID, and we're facing budget shortages. And the decision came down to, can we turn on the lights in the elementary school when school starts, or are we going to fund the syringe program? And I think we all know what choice was made, but that's unfortunate that we have to have, that these communities have to make these choices, but that's the reality in these resource deprived areas. So I definitely need to take a couple minutes just to highlight some of the presentations and discussions from this week. I hope everyone was able to hear the keynote on Monday from Dr. Frederique from the Drug Policy Alliance. She spoke so eloquently about the role of research in policy and how we as researchers can utilize research to fight back against policies that are not grounded in science. I suspect many of you have been fighting this battle in recent years, and I'm really hoping that the past couple weeks have shown that maybe we can turn the corner on that. She also reminded us both of the importance as well as the potential limitations of research in informing policy. Not all research has broad sweeping policy implications, but much of what we do around the epidemiology and treatment of substance use disorders can and does impact policy. And I think we need to continue to do that. It behooves us to ensure that the results of our research are reaching those who are making decisions at the local, state, and national level. The stigma session was also very enlightening. The moderator, Dr. Sosky, noted that oftentimes the stigma around addiction is worse than the addiction itself. And that really hit home for me. The folks that we've been working with for years in Hazard, Kentucky, as I mentioned, population 5,000, you know, when we talk about rural areas, I think there's the strength is that sense of community. And everyone knows everybody else, and everyone knows everybody else's business. So this very personal struggle is often played out in front of the entire community. And the panelists pointed out that the idea of stigma reduction is not all that simple. So who are these interventions aimed at is as important as what they're attempting to do in terms of reducing stigma. So there were some really thought-provoking ideas presented, and I certainly would encourage anyone who missed a session to go back and give it a listen. And then finally, I attended the policy research session yesterday, and one of the presentations, full disclosure, it was about Kentucky, so it really piqued my interest, was examining the role of the Good Samaritan laws on enactment of Good Samaritan laws on overdose mortality. And in this case, they looked at two predominantly rural states, Kentucky and Tennessee. And before I get into the results, I want once again to point out an issue that is almost always uniquely rural in nature when we're talking about preventing fatal overdose. So back in my undergraduate years, I was a data analyst at the Injury Prevention Research Center, and one of the data sets that I was tasked with analyzing involved ambulance run data for the state of Kentucky. This was pre-opioid epidemic, and I didn't necessarily know what I wanted to do with my life, so certainly substance use disorders and overdose were not necessarily on my mind. But what did strike me were the ambulance run times in some of these rural counties. 30 minutes, 40 minutes, and that's on a clear day in the summer. Could be a whole lot longer if there's snow, given many of these counties are in mountainous regions. And if you've ever driven in the area, some of the roads are absolutely death-defying, treacherous. And as we all know, most folks don't have the luxury of time when we're talking about overdose. So an obvious way to address this is to make sure that naloxone is readily available in these areas, especially where EMS response times are suboptimal. But there's the added difficulty of getting it in the hands of the people who are most likely to be present in the event of an overdose. So you all may be aware of the Healing Community Study. That's one of the new large-scale initiatives that really is seeking to reduce overdose in 4 states that have large rural populations. But then I started to think about the roads and the bridges, and that comes back to infrastructure. And I don't think we necessarily think about infrastructure as a way in which to potentially impact overdose. But the conditions of our roads and bridges may impact the ability of an ambulance to promptly respond to an overdose. If a bridge is washed out and is never repaired, it may take an extra 10 minutes to go the long way to get to someone's home. So to borrow from Elizabeth Warren, these are one of those big structural changes that may only seem, in our case, tangentially related to substance use disorder, but could most certainly have an impact. So back to the Good Samaritan Law and the excellent research presentation. So I'm happy to report there was indeed a positive impact in the state of Kentucky, about 25% reduction in overdose mortality in the years after the law was enacted. The effects were a little bit more muted in Tennessee, but hopefully once those 2019, 2020 data release, we'll start to see a sustained effect of the Good Samaritan Law on overdose mortality as well. And finally, as Jody mentioned, I'm a member of the External Advisory Committee for both Rhode Island Hospital and the University of Nebraska's COBRAs. And I'm in the unique position of watching these centers grow and prosper. And under the leadership of Doctors Jody Rich and Tracy Green, the COBRA on opioids and overdose has had phenomenal success in addressing the opioid crisis in Rhode Island. I'm particularly impressed with their ability not only to engage with the community, but also engage with the broader systems within their community and getting buy-in at the local, state, and federal level. So one of the projects that I absolutely love hearing about is their work in making naloxone available over the counter in Rhode Island pharmacies, which required them to engage with the chain pharmacies that are often not necessarily known for participation in harm reduction activities in the US. Certainly we've heard, especially in Australia, the ability of folks to actually leverage both pharmacies and pharmacists to provide treatment, testing, and linkage to care. We haven't had as much success in engaging pharmacies, and this is a fantastic first step in doing so. So the researchers at the Rhode Island COBRA are also tied in, interestingly, to data systems, I think more than a lot of other folks that I've talked to. And this is really important because the ability to analyze these administrative data sets allows us to not only identify problems at on a much broader scale, but also measure outcomes once we are able to actually implement interventions that will hopefully impact the problem that we're dealing with. So we oftentimes complain about administrative data and the inability to conduct more nuanced analyses given the structure of the data. But if you have a relationship with the folks who are collecting these data, these administrative data, like the relationships that the folks at the Rhode Island COBRA have established, then there's a great possibility that you can have some influence on the type of data they collect. It may just be 2 or 3 additional variables you need in order to be able to make your case. So having and establishing these relationships, I think, is something that the Rhode Island COBRA has done an excellent job at. And finally, I think they've done phenomenally well in engaging with their corrections facilities and those who are in the correction facilities. So we all know the important role corrections can play in both identifying and treating substance use disorder. And whether that's within the facility or the linkages to services that happen post-release, we know that's a very critical time, especially when we're talking about overdose. So designing and implementing jail and prison-based interventions, however, is impossible if you don't have a working relationship, a good working relationship with corrections. I can tell you that, you know, the folks in Rhode Island have really been at the forefront in leading the development of interventions and research in this area, and that's not the norm. There are many states where I know researchers just haven't been able to establish those relationships that will allow them to get into the facilities and to pilot some of these very important programs. So they have done a tremendous job in working with corrections to develop and test interventions aimed at addressing substance use disorder among those who are incarcerated. And as we've heard this week, we are certainly faced with unique challenges when attempting to address substance use disorder in rural areas. And that's where I'm so looking forward to being a part of Nebraska's rural substance use treatment, substance use research center. And obviously they can learn so much too from the Rhode Island Center. And, you know, there's not going to be obviously a whole lot of overlap given very different populations, but at the same time, what the Rhode Island COBRA team have developed in terms of leadership, the development of students and postdocs and early stage investigators and the cores provide an ideal model for COBRA development and sustainability, which is obviously a really important piece of this. So ideally, Nebraska's Rural Drug Addiction Research Center will generate new ideas for how to address substance use disorder in the rural context, as well as training the next generation of researchers who want to tackle this issue. And to that end, it's my hope, and I'm sure it's the hope of everyone involved in Nebraska's COBRE, that they will become a national leader in this area. And under the leadership of Dr. Bevins, I really have no doubt that we will be talking about the Nebraska COBRE in the same glowing terms we've used for the Rhode Island Center in just a year or two. And I really, again, look forward to being a part of the external advisory committee for that, so I can be front and center when they become the national leader in rural substance use disorder research. Thank you all so much.
That is wonderful. And just a great summary of what a week we've had. And great job. I think everyone's going to get an email form to fill out. And so please give us your input on how we should do that. We're definitely going to do this again, and we might do some smaller venues and shorter programs, bring some excellent speakers in. So any suggestions you have about for all of us, but this has been a wonderful three-way collaboration, and everybody who's participated in this has gained something. And I encourage you all to reach out to the people that you've connected to or even you've heard about, and let's put our heads together and try and figure out how to solve this complex problem.